I'm going to do a quick overview of some of the recent work that we've done, and then focus on about 3 or 4 things. So as for an outline, it's going to be an overview of selected key contributions. I just focused on a few things where, I played a key role in, say, providing leadership or being part of the leadership committee. And then I want to spend the rest of the time talking about some of the work that we started doing some 16 years ago around azithromycin used to prevent infections in pregnancy. And it's been a whole journey starting here, doing a multi-center study, and then extending to do a global trial. Then also talk about optimal timing of delivery, some of work that was done as part of the NIH Maternal Fetal Medicine Units Network that UAB has been part of for upwards of 30 years, and I've been the PI of the center here since 2009, and we've gone through multiple iterations and continue to do. Okay. Everything is here. Just and then finally, would like to talk about chronic hypertension because that's just a great collaborative work between the School of Medicine and the School of Public Health with Jeff Sakowski and Gary Cutter doing some of the work leading up to that. I have a bunch of slides, so I'm hoping we can get this. Is someone working on it?
Yes, someone
Okay.
should be here shortly.
Let me try something else.
It was working earlier.
All right. Okay, good. So that was the outline. I'll use this. So I want to start with global health because that's sort of where things began, and point out 2 publications here that made up my PhD dissertation. During this time, I was actually doing my residency in obstetrics and gynecology at Baylor, and just needed to get it done. And so to do this, did some upfront work, was able to get a small grant, 4,000 or so, and took a month off and went to Cameroon and visited the whole region out there, and went to all the districts and talked to people and did some surveys, all the maternity health workers. And the district medical officers were very supportive. And so we came back and talked about evidence-based reproductive health care in Cameroon, based on what was the World Health Organization Reproductive Health Library. And they had, I think, a number of recommendations that they thought would improve outcomes for mothers and infants. And when we did this study, it was woeful because some of the key things, the level of awareness ranged somewhere between 15 and 40%, and then the level of practice went somewhere between 10 and maybe 30%. So it was really bad for key things like steroids to improve lung maturity and prevent death, or HIV medication and treatment, or they did very well with preventing postpartum hemorrhage and giving utero tonics. The other thing was magnesium sulfate to prevent preeclampsia, so hypertensive disorders, and that wasn't good. And then we looked at the factors that were associated with the poor awareness, and also found, things like, I just haven't heard about this, or with respect to practice not having the supplies in place. And interestingly, being an OBGYN doctor in that setting was more likely, they were more likely to be aware and practice, which you would expect because of the training. And CME, having attended ongoing CME was also associated with being more likely to be aware. So I start with this and we'll circle back to this towards the end. But I want to also highlight this work around optimal timing of delivery. I will say more, and this is part of the NICHD network. This changed practice in the US and across the world. And we also did this work that I was senior author for with a resident at the time who got an major oral presentation here. And we were able to show that when you do what is called a fetal lung maturity test, which is getting fluid from around the baby and testing doing some biochemical testing to determine whether the baby was mature enough to be delivered. Yeah, those babies who got that positive test did better than those at the same gestational age who did not get the test, but did not do as well as those that were delivered later. So through this publication, we're able to just almost do away with the whole concept of fetal lung maturity testing, with a new mode of practice being that if you're very worried about, you don't have to test, go ahead and deliver. If you're going to test, then there is enough reason to wait to get to a gestational age where babies will do better. We also did a study with a fellow of ours here that also changed practice. At the time we were using staples to close C-section incisions, and a wound infection or a wound breakdown can be a huge deal for a new mother who is trying to obviously take care of the baby. And we were able to demonstrate that by borrowing from plastic surgery. If we did a subcuticular closure of the skin, and they did not have to come back and take out staples, those wounds actually, we were able to reduce the rate of wound breakdown by about 50%. And so there are a few other validating studies, and pretty much the standard of care is to use a suture rather than a staple. And then this work, I was also part of the major committee from the NICHB network, where preterm steroids were being given to reduce complications and reduce death associated with preterm birth prior to 34 weeks. So we only gave steroids up to 34 weeks, but through this trial, we were able to demonstrate that giving steroids also in the late preterm gestational age between 34 and 36 plus weeks would also improve outcomes for babies. So that is generally standard of care in the US currently. This work is one that I started doing with Gary Cotter and then subsequently Jeff, and it's actually built upon work that was previously done here. I'm going to say more about that, but it's something I really am proud of because it was, as those who are independently funded, know this was my first R01. So, and it takes a collaborative team, and this study was called CSOP, and you can see here PIs from multiple institutions around the US, but you can see Jeff Sikowski and Gary at the top and Gary Cotter down. And I learned a lot of things from Gary that I carry until this day. It's really just be patient, make it work. And some of the things that you spend a lot of time and, work hard and do investments to overcome may actually be an investment to the future. And in a way, that's what, happened with this CSOP trial, because many of the things we did, we struggled with this, underfunded, etc., that really set us up well for the trial that I'm going to talk about. And then just collaborating with others around the country, we also contributed literature to say that when the woman is completely dilated at the time of childbirth, do you wait for the baby to descend? So major question, or do you go ahead and deliver and start the lady pushing to deliver vaginally? And this study really moved the needle towards just going, once you attain complete dilatation, go ahead and push just to reduce some of the adverse outcomes that we saw, infection and other things associated with waiting for the baby to descend. And then finally, back to optimal timing of delivery. Labor induction is sort of an extension of what I'm going to talk about with respect to timing of delivery from a network study. But this was a follow-up study that got us to not wait until 41, 42 weeks to deliver women, but to even offer an induction of labor as early as 39 weeks. So most pregnancies now will be delivered at 39 weeks and generally no further than 40 weeks. And this was a huge change in a dictum that had existed for 40 years, where it was said that, if you do go ahead and do an induction, you increase the risk of a cesarean birth. But this study actually showed that you potentially reduce the risk of a cesarean birth by inducing early, 39, 40 weeks, as opposed to expectant management, and really reverse national recommendations. And the main reason for this was that the wrong comparison group was being used, right? If you do an induction, the comparison is not those who have a vaginal delivery, right? So induced versus those who were not induced and had vaginal delivery or spontaneous vaginal delivery. The comparison group is those who were expectantly managed, and they get managed, the baby grows bigger, and so some of them also still end up getting a C-section without going into labor. And I just showed to the side there, Dr. Drazen, who was the most recent editor of the New England Journal of Medicine. And as he was getting off 20 years into his tenure, he identified 12 articles that he thought had changed or had a major impact on healthcare. And there was one from obstetrics, and it was this study. So just a huge sea change with respect to what we did, and it was proud to be part of the group that presented and committee that developed this trial. And then finally, CHAP, we'll talk about CHAP, and then we'll also talk about Global Health, the Cameroon Health Initiative, global networks we are working with, and then the Mary Heersink Institute of Global Health, briefly. So in Cameroon, we work with what is called the Cameroon Health Initiative, and we have a number of studies going on with Jody Dion-Odom, who is with infectious disease. I think has given this talk. And one of them is called a MMIST intervention, and collaborating with a number of faculty here on that. And this MMIST intervention being done now goes back towards addressing what we found in early 2004 from my dissertation, and the goal is to have what is called the extension of UAB's medical information service via telephone, where frontline workers in peripheries will set up more experts to be able to provide them with help via mobile phone, and collaborating with Hena Budwani, who used to be here, and Anna Comfort, who also used to be in the School of Medicine. And this is, to me, one of the easiest pieces of work to do because of just everybody brought their part as an MPI, and multidisciplinary teamwork can really move forward that way. So we are there visiting our partners at the Cameroon Baptist Convention Health Services. It's a huge health service provider. It's number 2 after the government. This is one of their major hospitals there. They have about 8, and you can see, Dr. Budwani is there. We actually took a trip with Craig at the time here, director of SPACMAN, and Majid Zezefun was international medical education director for the School of Medicine, and just building partnerships there. And on that picture is the director of the system and also a dean of one of the medical schools that we work with. And so we're meeting here and signing a memorandum of understanding with the partners in Cameroon, with the lady Zach Pink, who is the president of the Anglo-Saxon University. Then briefly again on advancing global health, the Mary Heersink Institute, with collaborations going on with SPACMAN Center. The goal here is to organize things at the School of Medicine, where there is a lot of global health work going on in silos. And so our goal is to organize and then partner with other global health initiatives like SPACMAN or out of the School of Medicine to get work done. And the vision there is to improve health and promote equity in health outcomes around the world through the 3 core missions. And we have 3 main goals. One is to promote global health education and scholars being trainees and faculty. And this is really right side by side with the SPACMAN Center, and we are developing a master's in global health program that built upon the certificate course that is available. And then we are also working on creating a multinational network for collaboration across mission areas, with the key one being research, right? And also providing some services, especially through telehealth. And then finally, within the School of Medicine, we want to have a really organized structure and seminars, symposia, etc., some of which we're already doing in collaboration with Spatman. All right, so back to azithromycin and preventing infection. And here is John Houth, is a former chairman of my department for many years, and walked into, this is sometime after I came in as a fellow, and he walked in, and I see there are students, there is something here for you. He walked in and showed the hospital infection surveillance data for pregnant women and said, somebody needs to write this up, okay? And we looked around and I said, okay, I will try. So I picked it up, and that opened up just a huge, huge, path that I'm going to quickly outline. At the time, we were using here at UAB an antibiotic, azithromycin, in addition to what everyone else was using in the country. So based on prior studies that had been done by another former chairman, Bill Andrews, UAB was already doing things a bit different, but nobody in the country was doing anything like that. And we did a survey which showed that, well, it was only UAB or people who had some connections with UAB and people had trained here. So we started asking, why is this not taking hold elsewhere? People were not aware, people did not buy it. They thought it was just one small study. So this is what we found. This is the infection surveillance report that we did. And essentially, I hope you can see. So essentially, what we can see at the end there, 23%, I hope you can see that. This is all prior to a trial that was done during this period. So we're back in the 90s, and infection rates were like 23%. And somebody made the comment, did you all wash your hands in those days? When you So endometritis is an infection of the lining of the womb, and it's one of the most common infections you can have after cesarean delivery. Then they did a trial here where they added the azithromycin. It wasn't azithromycin they added, but a medication that would provide a similar coverage as azithromycin. And during this period, only about 24% of, or 25% of C-sections were part of the study and would have been exposed to the intervention. And you see a drop in the infection rate. And then from 2001, they started routinely using that after the positive finding from that trial, and look at what happened to our infection rates over time. So a dramatic reduction. We did another follow-up and reported, I'm not showing that, on wound infections, and also saw a similar pattern over time. And so, yeah, some say, well, maybe this, over time, things just got better, different, was, as we study in Epi, maybe there are other things going on that caused this. It wasn't randomized, so other things could explain. So we mounted, therefore, a trial, a multi-center trial, and it was simple. You get a C-section in labor. Those were the highest risks of C-section at highest risk. And you got your usual antibiotics, and then we randomized you to a placebo or to get the additional azithromycin. And this is what we found. This was obviously from the publication. And what you can see here is that the risk of the composite of endometritis, wound infections, and other infections reduced by 50%. And there were 14 sites across the country. So really dramatic reduction here. The endometritis reduced, wound infections, which can be, wound infections, which can be even worse than endometritis, even really well reduced. And then a number of other infections, less frequent, also reduced, although albeit not significantly. And if you look at the necrotizing fasciitis, we fear that, because this thing can kill, and 0 in the azithromycin group and 4 in the placebo group. And then if you look at abdominal or pelvic abscess, so the infection is really forming an abscess and generally warrants an operation, and also 0 and 4, and those are not the same patients. And then also looking at other secondary outcomes, fever, readmissions, on clinic visits that were unscheduled, emergency department visits, all reduced in the antibiotic group. And then the need to use antibiotics to treat also markedly reduced. So this just also indicated a potential huge benefit in terms of cost, right? Because these things are costly. So we did an economic analysis here. Really had a great time working with Dr. Kilgore, who is the second author on this. Just really fascinating. And at the end of it all, we concluded that azithromycin was cost saving, and came to the conclusion for every unscheduled cesarean delivery that's done in labor, you saved, for every dose of azithromycin that was given, you saved $360. For every dose that was given in the lower risk, on scheduled C-sections and lower risk, you save 143. If you assume that there are about 1,200 C-sections annually in the country, and about approximately half of them may be the laboring ones, then that corresponds to about $200 million saved per year. And then when you look at the scheduled ones as well and tally that up, that corresponds to about $300 million per year in savings by giving azithromycin to all patients who get a C-section. And it was really powerful because it did, for those who do cost studies, even for very low risk of infections like 2%, we reduced from 12 to 6 for the high risk. And for relative risk as low as 0.9, this still remained strong. So practices, were changed, and all around the country now, azithromycin is used for antibiotic prophylaxis with new guidelines from professional organizations. And then in addition, we wondered about other things. Azithromycin can do what is called change the newborn microbiome, and theoretically there are concerns about that, about atopy, about obesity, diabetes, and things like that. And also, in addition, when you use antibiotics, you worry about resistance and some theoretical concern about also pyloric stenosis, which can be a major complication, obstructive complication for the baby. So this led to additional studies, and one of my mentees is completing 2 R01 studies focused on bringing back the kids exposed to this intervention and doing neurodevelopment follow-up to see whether something happened there, and also looking at obesity and growth, etc. And the coordinating center is out here. And then we also followed that up with an international trial, which right here, the C-section rates are high. We get 25, 30% on average in the US, but in most other developing countries, C-section access is not as good, and maybe as low as 5%, but they still have high infection rates. So we thought, well, can we do something about vaginal delivery? So we also did a trial that randomized women who were anticipating a vaginal delivery to get azithromycin, gets usual care, but then randomize them to azithromycin or a placebo. And this is called the A+ study, which is funded by the Gates Foundation and NICHD. 8 centers in 7 countries around the world. We were planning to do 34,000 women, and the primary outcome was maternal or newborn sepsis or death. So 2 primary outcomes, 1 maternal sepsis or death, newborn sepsis or death. And we have just completed enrollment into this study with almost 30,000 enrolled, and the DMs, the Data Safety and Monitoring Board, said, you all stop. So we are in the process of figuring out what's going with this, and it should be a publication coming out soon. And that's us in Zambia, which is one of the sites, with team members from all of these countries, from NIH, and I'm sitting in the middle, and Wally Carlo is on the far right there, who is the neonatology director and the PI for our UAB Center of the Global Network. And so collaborating with him, we took this study to the global network. And hopefully we'll see what happens to mothers and their babies when treated with azithromycin during labor. All right, so I'm going to just keep track of time and move on to this one. So a 28-year-old lady getting a second pregnancy is 36 weeks and has a pregnancy that's uncomplicated, has a prior cesarean delivery, cesarean birth, and she is going to get a repeat cesarean. Just this morning, probably delivered about 3 patients like this. But my family will be in town next week, so can you deliver me at 36 and 5/7? And this was happening a lot because, you know, they say, oh, repeat, you're going to get a repeat. So, oh, 36 is really close to 37. So, oh, we'll just, your full term, oh, your term at 37, and we can deliver you. Whereas guidelines would say, wait until about 39 or 40 weeks before you deliver. But this was just happening a lot out of convenience. So we, and this was against a backdrop of rising cesarean rates. Again, as I said, a third of deliveries, and this elective repeats accounted for about 30 to 40% or so, and many being done for convenience prior to recommended time. So we actually did an observational study leveraging a registry that was available through the NIH, NICHD Maternal Fetal Medicine Units Network. And this involved 19 academic centers, and this information had been collected from 1999 to 2002 on all C-sections. And at this time, let's see, I had just, come here. I was still a fellow when I proposed this topic and this concept, and it was, accepted. So this was probably about 2006, this analysis was being done. And so we defined a population of all term deliveries, 37 weeks, singleton, without malformations, and we're just going to get a C-section because they had a prior C-section, not because there was another complication or indication requiring that. And the gestational age was based on completed weeks, and we used the best clinical estimate based on history and ultrasound measurements, and the primary outcome was a neonatal outcome composite that included death and a number of neonatal morbidities, including respiratory morbidity. So there were about 24,000 term repeat C-sections in that registry. We applied a careful number of exclusions and ended up with 13 that met the criteria for those who were just having their C-section repeat. So about 55% of them. Interestingly, dates were, the dating criteria were really quite good. First or second trimester ultrasound in 77% and only 23% based on their LMP and the third trimester ultrasound. And this is what people were doing. So about most, as recommended, were getting at 39 delivered at 39 weeks or later. But you can see about 36% were actually being delivered before 39 weeks, a third before 39 weeks. So that seemed like a problem. And when you looked at race and ethnicity, there was a disparity there with more whites being likely to be delivered early and blacks and Hispanics later. Okay. And this is what we found. So just to set this up, here is, those delivered at 37, 38, so gestational age at delivery. There's a p-value for trend here across as you go across. And here is, the frequency of this outcome. And then this is the relative risk adjusted with 39 weeks as the reference. And then, and then also 40 with 39 weeks as the reference. And as you can see, the frequency of that outcome was higher at 37 and higher at 38 compared to 39 weeks, about the same at 40, at 39 and 40, and there was a clear trend going on. I'm going to move through the next few slides here because just to show respiratory morbidity and the same pattern. This is respiratory morbidity that at term, if you have this, it's severe. RDS, also a similar pattern, mechanical ventilation, so requiring intubation, not as frequent, but you can see that there is a clear similar pattern there. Hypoglycemia, which can also affect neurodevelopment. It's kind of a similar pattern, and then suspected or proven sepsis, similar, and then admission to the NICU, also very similar. And then also stay in the hospital, use of resources, very similar pattern. So we also said, well, looking closer, 52% of this 36% delivered prior to 39 weeks were actually delivered within those last 3 days before 39 weeks. So between 38 and 4 and 38 and 6. And so we looked at this group and looked at the primary outcome. And even within those last 3 days, it's tough to actually have dating to that level of precision, but still an increase in the adverse outcomes. So we said rates were high, increased neonatal morbidities 2 to 4-fold at 37 weeks, 1.5 to 2-fold at 38 weeks, and all the professional organizations and Medicaid and others really jumped on this and called physicians to order. And you really, if you were going to deliver early, even now on labor and delivery, if I have to deliver at 38 weeks, there has to be a clear justification why. And in states like Florida, you may not get paid if you just deliver. So over time, these rates have dropped. There's been concern that by allowing women to go until later, there's been some concern that that may increase the risks of stillbirth, which is something we did not address. We just did a cost risk benefit ratio and said, well, for one stillbirth, the number of early deliveries that you will have to do will be really high. But this has been studied, I think, extensively and has not really demonstrated as material increase in stillbirth. So it's here in the US and internationally, the recommendation remains 39 weeks or later, unless there is an indication for which, preeclampsia and other things, you can go ahead and deliver early. All right, so moving on to chronic hypertension and a bit about CHAP. We were faced with a situation where, for treatment and BP control for women who have chronic hypertension, so pre-existing hypertension, prior to pregnancy, we know effective for the general population and highly, highly recommended. But when it came to pregnancy, there was uncertainty about the benefits and safety in pregnancy, that treatment may cause some of the babies to grow small as you reduce the mean arterial pressure, that negatively affects the flow of blood to the placenta and can cause babies to grow small. And there were studies and even some trials that suggested that, but overall, lots of issues around the quality. And for the longest time, as far back as 1990, recurrent calls for a trial to be done in pregnancy to determine whether we should treat women who have what is called mild or non-severe chronic hypertension. And this accounts for about 70 to 80% of those with chronic hypertension, so the large majority. It was clear that with those with severe hypertension, so 160 over 110 and above, you treat them to prevent the same complications that would occur outside of pregnancy. So the CHAP trial then, which was sort of the next step to the C-shop infection trial, we brought the same centers and then we realized we needed a lot more centers, an open label trial. We really debated whether to blind the treatment and really debated it and thought it was better to do an open label study, because in general, if you blind placebo, you lose the ability to act when you may want to, and people may actually end up knowing who is on placebo and who is not. So we decided to keep it open label. But ended up recruiting over 70 US centers. We're in clinical coordination in OBGYN, Center for Women's Reproductive Health and Data Coordination here with biostatistics funded by NHLBI and a great drug distribution center out of the VA, with the goal to evaluate the benefits and safety of antihypertensive therapy for mild chronic hypertension. Some people prefer non-severe chronic hypertension during pregnancy. And with a hypothesis that if you treat to weight goal less than 140/90, and just to be clear, this was designed before AHA and ACC came up with new criteria or goals for hypertension, getting that to 130/80. So if you treat to less than 140/90, and you can see the definition of what is called mild or non-severe hypertension there. That's the range of systolic and diastolic. During pregnancy, we hypothesize that it will reduce a number of adverse outcomes associated with hypertension without increasing the concern. What was the concern? Small for gestational age infants. And so we enrolled women with mild chronic hypertension in clinic based on their history, reviewing blood pressures, but also based on their blood pressures measured in clinic. They could have had been newly diagnosed early in pregnancy or came in with pre-existing diagnosis and had to be in before 23 weeks of gestation. We randomized them to treatment or non-treatment, and those who came in and were already on treatment had to demonstrate a blood pressure that was elevated, right, to get into the study. Whereas those who came in on treatment, you would expect that their blood pressure could be controlled, but we had to go back and review historically to make sure that they actually had mild chronic hypertension and had not been severe. And if they were, met criteria for mild, then they did not have to demonstrate an elevated blood pressure to get into the study. And so if you were in the active arm, you got labetalol or nifedipine, first-line medications to get your blood pressure below 140/90. And during clinic visits, during pregnancy, we escalated to make sure that got to goal. And then those in the no treatment or standard arm did not get treatment unless their blood pressure became severe. And we define that as 160/105. Severe, really, the cutoff for diastolic is 110, not 105, but we used 105 just to provide more confidence to the providers, because some may not want to wait until 110 without treating. So we thought something like this would help with adherence to the protocol. The primary outcome was what is called preeclampsia, a hypertensive disorder itself with severe features. Preterm birth before 35 weeks, that's what is called indicated, meaning there was a medical reason or complication, not just spontaneous preterm labor. Abruption, which is a separation of the placenta from its, it's from the womb and can be catastrophic. And then fetal or neonatal death. And we centrally and blindly adjudicated these outcomes. I'm not gonna go into the details here, but there was a clear definition for what was called preeclampsia with severe features shown here. And then the safety and major outcome then was small for gestational age, meaning these kids did not get to, were below 10 percentile for the population weight for their gestational age, generally adjusted as well for gender. And so less than the 10th percentile, we looked at that, and this is what we found. All right, so approximately 30,000 enrolled, and we ended up randomized, so screen 30,000, randomizing 2408. So for 12 screen, we ended up randomizing one. Some might say that's a really high rate of attrition, but the main reason, the top two reasons, were that many patients with chronic hypertension just did not have that blood pressure elevation during pregnancy when we were screening them, and some of that may have to do with the physiology of pregnancy, where it drops. It drops in the mid or second part of the first half of pregnancy, and then also those who came in late after 23 weeks. And then so we ended up enrolling at 60 plus sites, and active standard, and then followed 96-97% rate of follow-up. It was quite great. And this just shows that the baseline characteristics were balanced. In fact, some of the journal editor came out and said, this is too well balanced. And we said randomization works. You have a good trial, but you can see those who came in and were already on medication, 56%. You can see minorities. I mean, this chronic hypertension obviously is more prevalent in Blacks, so about 48% were Blacks, and then to add the Hispanics, so really majority minority. And then you can see about, really high BMI, because this also included weight gain in pregnancy. And then a good proportion were actually enrolled in the first trimester, right? This is really great. And then 16% had diabetes. And then this is interesting, just shows the blood pressure you can see here, everything is the same at randomizations. They start at the same place and at randomization. And then this is systolic, this is diastolic. And then for a good part of the pregnancy here, you see a clear delineation. It's modest, but it's clear delineation and or separation between those in the active arm, lower blood pressures, and those in the standard arm. Same thing with systolic. And then as complications start occurring later on, you can see blood pressures get closer. And what that meant was that we saw a reduction, modest reduction in the primary outcome, 37 to 30%. That corresponded to a number needed to treat of about 15. So we treated about 15 patients to be able to reduce one of these outcomes, which is quite great. But that still leaves us concerned that the primary outcome rate was still 30%. There is still more work to be done. And then this is the other way of showing this survival analysis, and pretty much mirrors the findings. Some would say this is the better way, the most valid way of showing it by taking time into consideration. So about hazard ratio of 0.79. And then the components of the primary outcome, including preeclampsia with severe features, indicated preterm birth, really concerning things, both significantly reduced. And then you can see abruption and death lower in those in the active arm, but obviously small, low rates and not significantly different. Subgroup analysis across multiple characteristics, and you can see just overall to the left here, showing that the findings overall mirrored what we had with the the overall findings, and we did not see any major significant difference by subgroups. Though some of them approximate 1 in some subgroups, and people might say, hey, do we need to do more there? But these are generally underpowered, and so the overall findings apply. The safety outcome, no difference. If you look at less than the 10th percentile to the left there, no difference. And then if you look at less than the 5th percentile, which is even more concerning, because that's the kind that is more likely to lead to a stillbirth, no difference, and slightly lower in those who were treated. And then other maternal outcomes, really bad things, not yet very frequent, but you can see lower in the active arm, but not significantly different. Preeclampsia, any preeclampsia was lower with treatment. Any severe hypertension was lower, and other types of subtypes of preeclampsia lower with active treatment. And then looking at a bunch of other neonatal outcomes, a composite of very severe neonatal morbidities, not different between groups, even though lower in the active group. And then clearly preterm birth now less than 37 as opposed to 35 indicated in the primary outcome, and any low birth weight lower in the treatment group. So we concluded that treatment reduces adverse pregnancy outcomes. You treat 15 to prevent 1, and did not impair fetal growth, and no other maternal or perinatal harm was observed. And we encouraged then that uniformly pregnant women who have pre-existing chronic hypertension or newly diagnosed early in pregnancy should be treated to a goal less than 140/9. And there are additional studies that we're doing we have funding to do a maternal long-term follow-up study. So we're following them up to 5 to 10 years since participation. And I hope we can follow longer after that. And then we're working on a submission to look at childhood outcomes. And then also within days of the publication, the American College of Obstetrics and Gynecology and the Society for Maternal Fetal Medicine, which is the professional association for high-risk OB doctors, came out with new guidelines to say treat this. And this happened within days, in fact, within less than a week, because this is something that had been hugely debated and everybody was waiting for this. And so we're able to confidentially share some information with them as things were being prepped for publication. And so they had all the information and were able to make some decisions, because sometimes things like this can take 5 years or even more to move from finding in a clinical trial to a new guideline. So we're very glad this happened. And then I also talked about the ancillary studies, maternal and child, but there is also the preeclampsia epigenetic study that we are working on, collaboration with Beth Hidalgo and Brian Irving. And this should really help provide additional information